Hi, I'm Michelle Rupp, host of AFMC TV. Thank you for joining us. AFMC TV is a place to consider as a healthcare hub. AFMC is a healthcare nonprofit. We specialize in making our lives, businesses, and communities healthy. This space was created to share information with the community. You'll hear from healthcare experts on a broad range of topics. Medical topics like immunizations and telehealth, to lifestyle topics like strengthening a routine or keeping your family hydrated. Our promise to you is to keep you informed in a digital way, providing useful information to you and your family. Again, thank you for joining us and welcome to AFMC TV. About the vaccine. In the next hour,
very hard to thing. This video will provide ideas and also make sure
Hello and welcome into this week's edition of AFMC TV. We're so glad you're joining us. You know, we're in the middle of October. October is Breast Cancer Awareness Month, and so today's show is dedicated to all things breast cancer. Joining us this morning is Dr. Stacy Smith-Foley, one of our friends out at Carti. Dr. Smith-Foley, thank you so much for joining us today.
Thank you so much, Michelle, for inviting me. I'm happy to be here.
So let's first start by talking about just breast cancer in general. I mean, it's something that, is it 1 in 5 or 1 in 8 women are faced with?
It's down to 1 in 6.
Or 1 in 6.
Okay. Yeah. So it's a common issue. And breast cancer doesn't discriminate. It doesn't care how much money you make. It really doesn't care your skin color, doesn't care how tall you are. It can happen to almost any woman. About 75% of the women we diagnose with breast cancer have no family history. So not having any family history is not as protective as most women assume.
Yes, I remember hearing years ago that it was so important to know your history. And while it is important to know your history, the history could start with you.
Exactly. It is extremely important to know your history as well, though, because women who have a strong family history of breast, ovarian, and some other cancers, they may have a genetic predisposition for developing breast cancer. And by knowing their family history and by advocating for themselves, they can undergo hereditary genetic testing, and a mutation can be identified before they ever develop cancer. So with the advances that we have in genetic testing and in early screening, early detection, there are some women who carry one of these genetic mutations that has a very high lifetime risk of developing breast cancer. And by monitoring them very closely, they may never develop breast cancer. We've created a whole new classification of patients that we're now calling previvors. They will never be a survivor because they can make decisions and they can be monitored in advance and never develop breast cancer.
That's astonishing. Just incredible. Just incredible. Well, let's talk some of the basics. You know, remind me of the age of when young women should have that first mammogram.
So for women who are at average risk, no family history, they should start screening at age 40. And we strongly recommend that women screen each year. There's a lot of misinformation out there about starting later than that or not having a mammogram as frequently. There's some misinformation that some older patients think that they can stop screening at a certain age. There's no expiration date. You know, as long as a woman is continuing to live a relatively independent life, she should continue to get yearly screening mammograms.
What about self-exams? Are those still important or is that outdated?
It's not outdated. I really think that it is important. I don't think that women should drive themselves crazy checking their breast and getting worried about every single lump that they feel. I recommend that women learn their lumps because most of us have lumpy tissue, right? But you need to be aware of your body. And if you notice any changes in the appearance or the way the breast feels, any discharge from the nipple, even dimpling on the skin, those would be some concerning findings, and you should talk to your doctor about those and be evaluated.
What about men? We associate breast cancer with women, but are men at all at risk?
So some men are at significant risk. Those men that have a family history of breast, ovarian, or a history of prostate cancer at a young age, they may carry one of those genetic mutations. These genetic mutations that we identify with hereditary genetic testing have a 50-50% chance of occurring in both men and women. So there are equal numbers of men that carry these mutations. There are some new studies that say that maybe performing mammograms on men who carry genetic mutations may allow us to diagnose cancer in them at a younger age and at an earlier stage of development. That is pretty new data, and I'm not sure how insurance companies are dealing with that yet. But in general, average risk men don't need to get mammograms, or they don't need to have breast cancer screening. But I would circle back to and say that men should also be aware of their bodies. And if a man feels a lump in his breast, that could be a very concerning thing. Most of the time, it ends up being a benign condition called gynecomastia. But in those rare occasions where it does represent breast cancer, when men are diagnosed, it's typically more advanced and has typically spread into the lymph nodes. So it can kind of present in a more aggressive stage because we're not doing screening in men.
How have we, as a country, watched the evolution of breast cancer? It used to be, at least in my mind, that wasn't something that you heard much about. And even the statistic as we started out, 1 in 6 now will be diagnosed. It is very much a part of our conversations, a part of our lives, whereas it used to not be. So how do you think we got there? Or have we always been there? We just didn't talk about it.
It may be that we talk about it more, that this generation of women is more open to talking about intimate details. Some older women feel ashamed or embarrassed about their bodies, and they're reluctant to even talk to their doctors about anything they might notice. I think we also have technology that allows us to detect breast cancer in an earlier phase. So because we are screening patients, we're finding more cancers. Because our tools have improved, we now have 3D mammography, also known as digital breast tomosynthesis. We are finding more cancers with that tool, and we're talking about it more as well.
What are some of the, and you've touched on it, but some of the new technologies, some of the fun things that you guys are doing out at Carti?
So we offer high resolution 3D mammography, and we actually have some artificial intelligence built into helping us interpret those examinations. So those are the latest and greatest things. The high resolution 3D mammography. Now we're seeing a lot of AI being introduced, clinically relevant AI introduced into practice, as well as supplemental screening with ultrasound for patients with dense breast tissue, and MRI for those patients who are at an increased risk.
Okay, so more technique, more tools in the toolbox.
Right. And I think we take a different approach in this day and age. There's not a one size fits all solution. We really try to customize the solution to fit each patient's circumstance. So you may have a patient that doesn't have any family history, but they have a very dense breast. They would benefit from supplemental screening with ultrasound. On the other hand, you may have a patient that doesn't really have dense breast tissue, which is a very strong family history, and she has more than a 20% lifetime risk of developing breast cancer. Those women need to supplement their mammogram with an MRI. But the mammogram is always the base. We don't ever give up the mammogram for the in place of the other tests or tools. We use the other tools as an addition or a supplement to the mammogram.
So it is 2021. Any way to make those mammograms a little more pleasant of an experience?
Well, I will say that the vast majority of our patients would describe their experience as more pleasant.
Good.
Yes, we have a lot of techniques and some new tools that make the examination more comfortable. We have ergonomic paddles. You know, the breast is not a flat structure, it's curved. So we have an ergonomic curved paddle that our technologists use on some patients. We also have some comfort devices. We have a certain kind of, it's a blanket. It kind of feels like a felt blanket that goes over the mammogram unit, and it prevents getting a tear underneath the breast. And other women, we will use a foam pad to kind of reduce the amount of compression. With the high resolution 3D mammography, we really don't have to compress the breast as flat as a pancake, like a lot of women remember their prior experiences. And our staff really works with patients. You know, we have a lot of people who have had a bad experience. And so if you have a bad experience, you don't want to do it again. We see so many people that just stop. They had a bad experience and they said, I'm not doing that again. And something's brought them back. And we just work with them through that. You know, we tell patients, we are only going to compress you to your tolerance. No one is going to, you know, slap your tissue up there and smash it down and crank it down. If the patient is experiencing some discomfort, we dial it back. And, you know, there are some patients that just refuse to have a mammogram, period. For those patients, we have alternatives, ultrasound or MRI. They're not ideal. Like the gold standard is the mammogram, but I would rather have a patient have some form of breast imaging than no breast imaging at all.
Sure. And we should mention that should you receive a breast cancer diagnosis, it's not necessarily fatal.
No, it's not always a life-threatening situation. You know, we find very small breast cancers with the digital breast tomosynthesis, the 3D mammography technology. We find cancers smaller than a centimeter in size that are very treatable. The vast majority of these women can undergo breast conserving therapy. They can have a lumpectomy. They don't have to have their breast removed. Many of them don't even require chemotherapy. They can have, you know, an easier treatment for an earlier form of the disease when it's diagnosed at an early stage.
And that's the key right there.
It is.
Early detection and any prevention.
Right. Correct.
Fantastic. Well, Dr. Smith-Foley, is there anything else that you would like to add?
Well, I would like to add that there seem to be some concerns among women about COVID-19 and the vaccine and how that might impact a woman's mammogram. We have so many women who delayed or deferred getting a mammogram last year due to the pandemic. And as a result, we are seeing more and more breast cancer diagnoses because those cancers were there. Those women just didn't come. There should be no concern about having your mammogram and how your COVID vaccine might impact your mammogram. If you haven't had your vaccine, go ahead and get your vaccine. If it's time to get your mammogram, get your mammogram. Some women may experience a transient enlargement of their lymph nodes due to the vaccine, but that's something we're familiar with. We occasionally have to bring patients back in to do an ultrasound and to do some additional imaging. We may even have to do a follow-up. Rarely do we have to do a biopsy in these ladies. But I would encourage women to get the vaccine. Don't delay in the vaccine and don't delay in getting your mammogram.
Very important advice and something that we all need to take. So thank you. Thank you so much for joining us today. It's been a pleasure.
Thank you so much.
Thank you so much for joining us today. We'll see you back here next Wednesday for more AFMC TV.